Okay, good evening, colleagues. We'll make a start. Good evening, colleagues, and thank you for joining the COVID Champions webinar with Public Health Birmingham. On the call today, we have Public Health Birmingham consultant, Dr. Medupe Amanuju, and we also have two colleagues from Public Health England who will introduce themselves when they come onto the agenda. And they're going to share with you and discuss some findings, some research that they've been involved in about the Champions program nationally and also similar programs that have run internationally as well. As per usual, Zoom etiquette, please keep your mics on mute. Do use the chat function for questions or comments or to indicate you'd like to voice a question. You can also use the hands up icon to indicate you'd like to voice a question. The call is being recorded for minutes purposes and can be viewed on our YouTube channel link, and that link's in the newsletter. And I've also just put it in the group chat. The agenda, welcome and intro for myself. Then Dr. Medupe Amanuju will do a quick COVID update. Then I've got a new agenda item around you asked, so just giving you some feedback around some of the questions that, or some of the issues that you raised at the last meeting. Then we've got our Public Health England colleagues that will discuss the research that they've been involved in, any other business, and date of next meeting, which is Wednesday, the 15th of September at 6 p.m. I'll hand you straight over to Medupe. Whilst Medupe is introducing herself, I'll just bring the slides up, Medupe, for you. You're going to go ahead and start, and I'll bring the slides up for you.
Thank you very much, Habib. Good evening, everyone, and welcome to this week's COVID Champions session. As Habib mentioned, we have a packed agenda today because we have Public Health England colleagues here to share some information and get some information from champions as well. So thank you to everyone who is attended today. With regards to the COVID update, the dashboard should be ready now on the website. So I'll just go through some of the findings that we've got from our analysis of the COVID rates across the city, which is looking promising in that the new cases have fallen, not hugely, but about just under 400 cases in the week ending the 29th of August. Our case rate also fell from 313.2 per 100,000 to 276.4 per 100,000. Rates of testing have gone up from 5,402 to 5,660 persons tested per 100,000 using both PCR and lateral flow device tests. And one other area to note is that our rates, or actually a proportion of positive tests, so the percentage of positive tests out of the 5,660 tests per 100,000 taken were 14.3%, which is a drop from the previous week. And that's really good to see, because that suggests that compared to before, where we had testing rates that were falling or positivity rates going up, it suggests that there's been a slight improvement there. But as you can see, there are still a lot of people who are testing positive. So we're not out of the woods yet. COVID is still with us. And as we continue to learn to live with COVID, our messages are still that people should take personal responsibility, continue to wash their hands, continue to wear face coverings when they go out to places where they're not sure about the crowd or whether there's going to be good ventilation, and to continue to do the lateral flow testing on a regular basis. Across our hospitals, our cases ranged from 31 to 45 new cases per day. On that same week ending the 29th of August, that made a total of 263 cases in hospital with COVID-19, which was a fall from the previous week when we had 306 people on admission. Sadly, we had 19 deaths reported, which was an increase of one person from the previous week. So there are still, sadly, people dying from COVID-19, as we know, not just in this city, but across the country and globally. So we continue to encourage caution as we take advantage of the lifting of restrictions. One of the things that we do, which is to look at cases at ward level, as Habib will show you on the next slide, shows that, again, it's interesting that we have wards that the cases vary from ward to ward. And this particular week, you can see the darker wards at the bottom of the map, where there are more cases being highlighted, where we think, again, basically, as a result of the number of people testing, there are more people living with COVID-19. But as we always say on a regular basis, we cannot rely on just this because the rates of testing vary across the city. But based on this week's data, it suggests that those wards at the bottom of the map and a few dotted on the right and at the top have more cases per 100,000. And these top wards with more cases and compared to the cases we have in the city are Sutton Trinity, Northfield, Bourneville and Cottridge, Garrett's Green, Batley Green, Hyters Heath, Druids Heath and Morney Hall, Shad End, Longbridge and West Heath, Sutton Four Oaks, where the wards with these high rates range from 393 to 540 per 100,000. And when you compare that with the 276.4 per 100,000 in the city, you can see that these are wards where people are perhaps facing higher rates of infection. So we continue to encourage people to remain cautious and to be mindful that we are still living with COVID-19. When we look at the age groups, again, we can see that it appears that in the younger age groups, there's been a decrease from the 0 to 19 years by about 16%, it says on the report. Bearing in mind that we know that they've been on holidays, the children, so there hasn't been as much testing. And from next week, we expect to see more testing in education settings, and these might go up. Well, we hope not, but we'll continue to keep an eye on this and keep you all posted. Across the ethnic groups, again, we've seen a decrease in all ethnic groups. It says here, except the mixed and other ethnic groups, where we've seen a stable case rate. And we've seen in particular that within the Black ethnic groups, there's been a decrease by about 46%, which again might be perhaps an indication that there might not be as much testing within those groups, but we just have to keep monitoring and keeping you posted on these figures. We'll skip the next slide, which is just more detail about case rates for every single ward, 69 of the 69 wards across the city, and go straight to the vaccine slide. And we're very happy to report the uptake in the 16 to 17-year-olds is increasing. As you can see, first doses have now gone just over 20%, nearly 25%, which is really promising. And we continue to work with the NHS to ensure that as many people as possible can come up and take the vaccines when they're offered. We are still keen to get more people who work in adult social care in particular to get their vaccines as we approach the deadline for these workers for mandatory vaccination. And the last slide just shows you which wards have the lowest uptake, where the uptake is below 60%. As you can see, it's the same wards that we've been reporting on a weekly basis. And we continue to encourage those of you who are champions in those wards to feed back to us any concerns that people in those communities may have around vaccination so we can continue to support them. And more importantly, I think when the vaccine vans are going out, to do as much as you can, again, to raise awareness through your contacts and your network so that people can be available to take the vaccines when they're offered to them at their doorstep. So I'm going to stop there and just see if there are any questions, Habib. Thank you.
Thank you, Medupe. Can I just ask colleagues or the champions, is there any questions pertaining to the presentation or the data that Dr. Omanuja just shared? If you can leave any other questions till the end, I'd really appreciate that. I'm just conscious of the time and I want to use up the time effectively in terms of giving our PhD colleagues sufficient time for their discussion. So if there's any questions with regards to the presentation that Medupe just did, if you can ask that now. Anybody? Any questions? Okay, that's great. We'll just move on to the next agenda item. And this is something new that I'll just put in. It's around you asked. So this is just sharing responses to some of the questions that you raised at the last webinar. And the first one was there's lots of issues around the GP access. So we did say to you that we'll arrange a GP. So we've got a GP that will come to the next webinar on the 15th of September. If people have got questions that they'd like to raise with the GP, you can email them over to myself. So the GP is ready with the answers. And obviously there's questions that you can ask the GP on the day as well. But if there's questions that you can kind of like send beforehand, that will really help in terms of time as well. So we've got a GP, you raised issues around GP access. We've got a GP joining on the 15th of September. You also wanted the data link to be included in the newsletter, and it has been. Last week's edition and this week's edition, the link to the data dashboard is in the newsletter. So if you want to have a deeper dive into the figures and the data that Madupe shared, you can do that at your leisure. Also, link to view previous meetings is also in the newsletter. We've got a YouTube channel, and that's in the newsletter as well. And you can view previous meetings, what was discussed, what wasn't discussed in that. And lastly, I know at the last two webinars, colleagues raised the issue around what support schools will be getting around ventilation. Well, I can say to you, last week, the government, on the 21st of August, the government announced they'll begin a rollout of carbon dioxide monitors, and that's going to be backed by 25 million pound of government funding towards education settings. And what these monitors do is they actually monitor or they read from across indoor spaces in your settings, providing you reassurance around existing, to see if your existing ventilation measures are working, and helping you balance the need for good ventilation with keeping classrooms warm. So it measures how much carbon dioxide is actually in your room. So I just thought I'll share that with yourselves, and the link to that information I'll put in the group chat later on. So I just thought I'll give you an update on that. Okay, so I'll hand you straight over to two colleagues from Public Health England. They can introduce themselves, and then when you're ready, Jane and Tom, let me know and I'll bring the slides up. Or if you want, I'll bring the slides up as you're introducing yourself. Over to yourself, Jane, Tom.
Shall I start, Tom? I'm Jane South. I'm a professor of healthy communities. I actually work in Leeds, but also work with Public Health England in the national team around healthy communities.
Thanks, Jane. I'm Tom Mapplethorpe. I work with Jane in Public Health England. I'm also part of the Healthy Communities team in Public Health England.
Thank you for that. Yeah.
Do you want me to?
Yeah. Jane, Tom, over to yourselves.
Yeah, I'll take the first couple of slides. If we can move on to the next one, Habib.
Yeah.
Yeah. So thanks for letting us join today. Really appreciate you letting us join and talk about the work that we've been doing. We've been doing quite a bit of work around community champions programs and schemes over the past coming up to 9 months now, since the funding from the Ministry of Housing, Communities and Local Government came out. So we've done various pieces of work. We've done webinars, we've pulled together case studies, but what we're here to talk about today is some research that we've done, which is a rapid review of some of the evidence around community champions programs. So just looking to the slide then, what we want to do today is share our findings with you from the research that we've done, to kind of give you a chance to tell us your thoughts about what we found and how it relates to your experiences and what you do as champions. It's what we're really interested in finding out. To discuss how public health can work with champions such as yourselves in the future. It's the best way of doing that. And kind of to do all of that, we want to be able to capture some of this, capture your thoughts, your feedback, your perspectives and experiences. We're going to pull together a quick kind of briefing note, obviously just to say that anything that you contribute will of course be included anonymously, and we'll share the note with you afterwards for your information too. And next slide, and I think I'm passing over to Jane.
Yeah, so hi, if I can like to echo Tom, thank you very much for having us at your meeting. And I know a lot have heard from Justin and Madupe and Habib, a lot of the work that all of you have been doing over a number of months now, so which I think is great. So I'm going to talk you through the results of our research. But before I start, I just wanted to focus on what we've been focusing on. So the idea of community champions or health champions has been around for quite a while. And we know that community champions can come from all walks of life, and also that many different areas in the country involve champions in different ways. So here's the broad definition that we used, that community champions, who are also known sometimes as health champions, are members of the public who volunteer to promote health or well-being where they live and work. And they may also be involved in helping improve conditions in their local community. And champions use their social networks and life experience to connect with people and improve links between local services. And often the concern is where communities are disadvantaged or more have greater health risks. And we know that lots of councils have started to use champion schemes during the pandemic to help improve and reduce their pandemic response and reduce risk around COVID. And it's just a little advert which for an example from Dudley, trying to recruit people to become champions. If we go on to the next slide, please. So when local councils started recruiting community champions, probably around 9-10 months ago, to help with messages about COVID, we decided that it would be useful to look at previous research to see what we could find out about champions. So the purpose of this review was to scope the potential for community champion approaches as a way of improving the COVID-19 response and also potentially helping communities recover from the impacts of the pandemic. And we looked at things like, in the review, different champion roles and how they work, different ways of developing champion schemes or networks, and also what public health can do to support and grow champion schemes over time. So if we go on to the next slide. Thank you. So just to explain a little bit about what we covered, because COVID community champions are really new and there's hardly any research on COVID community champions, certainly when we started. So we had to think, well, what research is available that we could do an objective summary of? And this slide shows the two areas of research we were interested in. So we looked at international research on the role of champions or similar roles to champions in other pandemics or in other outbreaks where volunteers were helping prevent infectious diseases like Ebola and HIV. And then we also looked at UK research on community health champion schemes before the pandemic, where champions tended to be involved in promoting health or healthy living activities in their communities. And as you see the little bit, not much research yet on COVID community champions, which is why we wanted to look at this other areas. And in the end, we identified 52 pieces of relevant research, roughly split half and half between the UK and research from other countries. And I'm now going to present some of the findings from that. And hopefully you'll find this sort of interesting and some of it will sort of chime with what you've been doing. So if we go on to the next slide. So in terms of the international evidence, what we found is that community volunteers can play an important role in health emergencies and in the prevention of infectious diseases like Ebola and HIV. And we found two different models which share similarities with the UK community champions, popular opinion leaders and community mobilisers. Popular opinion leader schemes work by recruiting and training people who are either sort of well placed within their social networks or have a lot of influence, they're already community leaders and well known in the community. And then those volunteers promote health and ways to reduce risk as part of their daily lives. This has mostly been used for HIV prevention, and they have found that popular opinion leader things can help reduce stigma because people are from those communities. The other model was community mobilisers, and this is where a role where people work in large community teams, making sure that the information flows from communities and to communities. Large numbers of community mobilisers were recruited as part of comprehensive whole area approaches to prevention, for example, in the Ebola response in Africa and in polio vaccination. And looking at this evidence, we found that popular opinion leaders and community mobilisers are able to reach into communities and successfully communicate health messages. There was mixed evidence, though, both positive and negative, that these schemes have an impact on people's behaviours. And that may just be because that's quite difficult, as you'll appreciate, to measure. So that's the international evidence. Obviously, there's not much UK evidence on preventing infectious diseases before the COVID pandemic, because that wasn't a major problem in the UK. And if you go on to the next slide, I just thought I'd share with you an example from the States of how people have translated some of that international evidence that existed before COVID into something that looks a bit like a champion scheme. So in Milwaukee, in America, they recognize that they're learning from HIV prevention using the popular opinion leader model might be relevant to COVID-19 because they saw similarities in terms of the impact on racial inequalities, stigma, and mistrust in doctors. So what they developed is a hometown heroes intervention, and their aim was to recruit 1,000 community leaders, principally from ethnic minority communities in the city and others, and also from social influencers who already have social media networks. And then these trusted sources become heroes, which give out information to their communities virtually, including not just about risk reduction, but also things about promoting good mental health. And I thought you'd like to see that example, to see how some of that sort of evidence that we had before could possibly be linked to what people are doing now in the COVID pandemic. Okay, if we go on to the next slide, I said we also looked at UK evidence on community champions. So there are a number of community champion schemes before COVID, which usually focused on recruiting a network of volunteers who support people to engage in healthy living activities. And those, again, like popular opinion leaders, community champions communicate with other people as part of their daily lives. We found evidence that community champions are good connectors, especially in disadvantaged communities, where they can be a crucial link between those services and between communities and services. Most of the evidence we looked at in the UK comes from practical applied research done in one area or with one group of people. However, this almost always shows positive benefits to the community champions and some positive impacts reported for wider communities. So I think the sort of story is very similar across all the research. And we also looked at some local councils have developed COVID community champion schemes, but we didn't find any research about these yet. So we're trying to apply again the research that's gone on before. If we go on to the next slide. We looked at the ways in the UK people had developed community schemes in the UK, and there was a real mix, as this sort of diagram shows, but lots and lots of common ideas. Where schemes did differ is in terms of how much control champions had in deciding what they wanted to do in their community. So if you look at the yellow and purple rings, the empowerment approaches tend to use community development methods to support individuals and communities to organise activities and communicate messages on what they think is important. And capacity building approaches focus on building up a group of champions who become community leaders on health and have influence in their community. The other approaches such as sort of like strengthening participation and integrated approaches, tended to focus more on existing services. So champions supported what was going on, often being key connectors and helping people join in, or being a link between a service and community. For example, helping tell people about what local services were available, but they didn't tend to design those services or have much input into what the priorities were. So those were sort of broadly the different sorts of approaches we saw before the pandemic. If you go to the next slide, we also looked at what the research showed around what mattered when people in public health were trying to build up community champion schemes. And here's the sort of 6 points that we got out of it. So when people want to build successful long-term champion schemes, the research told us that recognising that people bring lots of knowledge about their communities and lots of valuable life experience was important. And this should be the basis of recruitment, not what job or education a person has. That's not that relevant to being a champion. Having training that builds skills and confidence as well as knowledge is important in the long term for champions. Having a local scheme or organisation that can provide support, coordinate activity and make sure champions can connect to other champions, a bit like the network that you've got at the moment and the weekly meetings. That's quite important for long-term sustainability. Having good community engagement as the foundation, that means listening to champions and acting on community priorities. Taking time to build trust and to build relationships, again, another critical factor in successful champion schemes. And ongoing partnership working between public health, voluntary and community organisations and communities. And these are all the things that were critical factors the research told us from before the pandemic, but it will be interesting to hear what you think, whether these are still factors during the pandemic with your roles. So on to the next slide, really, just to sum up what the key messages are from the review that we have been communicating through Public Health England. The first is that community champion schemes play a part in improving health and reducing health inequalities, and that's relevant whether it's an emergency like the current pandemic or a more long-term issue, for example, promoting good mental health. The champion approach can be applied flexibly in different communities. No single model stands out. And although that might sound like a bit of a cop-out, I think it's an important finding because there's not about the local model that works is the model that works for you. Making sure there is training, support and local coordination will help build a legacy for the COVID champion schemes as they develop and become more long-term. And finally, volunteers who have credibility and connections in a community are really valuable. But these roles don't operate in isolation and should be part of a wider approach from public health to work with communities. So that's our main messages that Public Health England has been taking from the review. And really that's the end of the sort of summary of the review. I hope that you've got something from that, and I will hand over to Tom.
Thanks, Jane. Yeah, next slide, please, Habib. So really, that's a summary of what we found, and really it's over to you now to tell us what you think about that. So a few kind of pointers or prompts that we hope will get you thinking. So thinking about the findings, do they match your experience as champions and what you've been doing? Is there anything that came up that was surprising, or something that didn't come up that you thought would be there or would be more prominent or important? What do you think the most important messages are, and who needs to hear them? And how can we build on what we've learned about COVID champions to take it forward into the future? So please do unmute yourself or type in the chat if you're more comfortable doing that. We're really eager to hear what you think.
I'll put some commentary in if it's useful.
Yes.
My name's Michael Thorne. I'm a community worker in a place called Walshhouse Farm, which is in Harborne. I actually had COVID pretty badly back in January, and what I decided to do as I say, community champion, was just basically tell the story of what COVID did to me. I'm not sure if any of you saw the piece in the Evening Mail. I actually told the story of what COVID did to me. Jane contacted me, and I said, look, I want to get this story out there, because I know there are people in my community who just do not believe that COVID is a thing. But it was quite surprising when it went on Facebook. It seemed it got a lot of really good positive sort of response, where I had people literally contacting me, said, after reading your story, I'm going to take the vaccine. So I think, I mean, I haven't got the resources to sort of do this every day, with my work and stuff like that. But I was trying to think of the messaging that sometimes comes out from people who are not connected to our communities. And they always seem to be talking down people, especially from the Black and Asian communities, that we've got this issue with health inequalities and stuff like that. I think it's important when people who don't look like us actually give people who are doctors, who are Black, from ethnic minorities, the opportunity to actually tell what COVID is and what the impact is, and then probably find people who've gone through it, like myself, to actually be somebody there that they can put the face to, that they can understand what COVID is. So again, I'm not here to sort of promote myself or whatever, but I just thought it was an innovative way of doing it, and I can tell you probably about 30 or 40 people contacted me privately on Facebook saying the story was that good that they considered taking the COVID vaccine. So yeah, there's other ways and other means, but that's just one angle I'm just trying to throw in there. So I hope that's useful. Thank you.
Yeah, really useful. Thank you for sharing that, sharing your experiences. Stories always comes up as something that's really important in terms of getting a message across or getting something across. So that's really helpful.
Anybody
else?
Question? Sorry, Tom, there is a question in the group chat, and I think maybe Medupe can take this one. It's from Teresa. Medupe, Teresa asking, how does this evaluation of community champions, or this research that Jane and Tom have done, tie in with the evaluation that's been undertaken by University of Birmingham for our scheme, our program that we're running? Medupe still with us? I'm just trying to think if Medupe is still with us. I think
Medupe left us.
Okay. Jane and Tom, are you aware of the fact that there is a review going on? Yeah. Do you want to comment on that? How our review will tie into yours?
Yeah. As I said, I think our job was to look at previous research to see if it could give us some of the answers as to sort of what the evidence was that we could use nationally in Public Health England and tell other people in the, the sort of public health world and health service world about the value of community champions. Whereas the evaluation in Birmingham will be looking probably, I would imagine, from having conversations with Medupe, at the how your scheme works and what the sort of impacts of that scheme are, how effective it's been. And that both those things are really important, what's gone before and trying to understand what's what works and who it works for locally.
Yeah, I'd concur with that. Thank you for that, Jane. Hopefully that answers your question, Teresa. It does, yeah.
Is there anybody else
Yep.
that wants to come in?
If I could say something about community champions. I'm Ruth Lockley. When I retired from the NHS, where I had worked in infectious diseases back in 2012, I was involved for at least 3 years with a local charity that already had been very involved in training community champions for not just around communicable disease, but around all kinds of health problems. And the groups were mostly in Birmingham and in Smethwick that I was in touch with, but I also helped with training for the Red Cross, and I was mostly doing training around tuberculosis, and particularly latent tuberculosis. And they were just an amazing group of people. A lot of them were from immigrant communities. Some of them had a health services background. Subsequently, some of them came up to me at various other meetings and said, you know, I found a job with the Red Cross, or I'm working in the NHS now. But we did a major project with the NHS around a latent TB that centered around a college that taught English as a second language to recent immigrants. And that was because Heartlands Hospital or the Birmingham Chest Clinic wanted to start the latent TB testing program in those groups of people, which that was subsequently done and has gone on since then because it became a national policy. But what I would say was that the really disappointing thing was, I mean, they were having come out of a lifetime working in the NHS into the voluntary sector. These were a phenomenal group of people to work with. They were absolutely astonishing. But it seemed to me that in 2015, 2016 maybe latest, the whole thing kind of went out of fashion and the funding was no longer available. And I also got the impression, which was really strange having come from the NHS, that the NHS wasn't absolutely sure how to work, either in general practice or from secondary care, with this group of volunteers and a charity. And that I found it really distressing. I mean, the work ceased because there was funding and then the project didn't go ahead. And so I had to go off and find other things to do. But it's just a comment on your previous research of community champions that I found them to be, coming out of the NHS, I found them to be totally inspiring group of people that I wished I'd known about before. And yet the scheme kind of faded away. And one of the best organisers of it in Smethwick, the last time I heard from her, she hadn't actually been able to find further work in that field, which was a real shame because she was a fantastic person who would take out groups to almost anywhere, you know, to supermarkets, to schools, to anywhere that wanted them, and actually, you know, deliver to communities through people from all kinds of backgrounds who echoed or mirrored the communities that were visiting that place. So that's just a retrospective on how it's been in the past with community champions.
Thank you for sharing that, Ruth. I think Ted's got his hand up before Tom, you want to come in?
Yeah, I arrived late, so I didn't see the first part of it, but I found the sort of the latter screens fascinating. Having been somebody who in the late 80s and early 90s was part of the HIV sort of, we weren't called community champions in those days, but we worked in the voluntary sector around developing understanding and messaging and stuff like that. I think, sort of going on from Ruth's part, I think one of the difficulties I've had working with organizations over the past like 10, 15 years about stuff is that the name that we give to community champions just changes so often. You know, we got patients by expert, experts by patient partners, and all these bits and pieces. And the whole thing is to actually get information out there to people who will talk to other people, who will dispel myths, who will provide information, stuff like that. And in some ways, it's partly because it's not I don't believe it's ever been taken seriously enough by health workers to understand the significant role of either voluntary sector organizations or community groups or even individuals in getting those messages out there. And I think your your circular semi-Venn diagram just explains why there's been such a mishmash of successes and failures. Because if you asked somebody what capacity building was, your definition is in there, which I would agree with, but you would end up with, you know, there's 15 of us in this call or wherever it is, you'd end up with 16 or 20 definitions of what capacity building was and stuff like that. So I really like the way you've been succinct in drawing it down. And I think what I hope the Birmingham research will bring out is how much impact the community champions have had, because I've used it because some of the groups I work with, I'm not a frontline worker, I support organizations in doing frontline activity and stuff like that. But when you've got advice and guidance workers, when you've got sort of like voluntary sector health workers and stuff, you know, one organization dealt with like 5,500 people in the first 6 months of COVID. They haven't got time to read all the bits and pieces, and that's what I'm for. And then I pass the bits on to them and stuff like that. So you need to get this, you need to get that, you need to get this message out, you need whatever. And that then influences their frontline work. It's looking at those bits, and it's being trusted by health professionals. I think that's the one thing I wanted to say, is that I think Birmingham Public Health within this one has trusted the champions with information and with data, you know, so that we can share it and we can actually start getting some of those messages out there, as I think, you know, our two previous speakers have gone. So it's not really a question. Hopefully you'll carry on your research and Birmingham will carry on theirs. But I think it's this sort of background stuff I found fascinating, actually, and we'll look forward to sort of reading the report and stuff.
Jane, you got your hand up? Jane, you mute yourself. You had your hand up?
Me?
Yeah.
Yes. Yeah, just want to come back to Ted to say I agree, and sometimes the names and jargon around all of these type of things massively get in the way to, you know, describing. In some way I think champions is, well, it'd be interesting to hear what other people say, but I think it's quite a nice term, but it does mean different things to different people, and other people are doing champion roles in other ways, and it's not necessarily recognised. So we do have to try and distill what the important messages are in terms of the evidence and the value of these sorts of roles. I think that's it's a challenge for the research community and the sort of public services. I think it's not a challenge. You guys are doing that work, but we need to sort of describe it better.
Are there any other reflections or thoughts? I guess get the feeling that a lot of this really matches with your kind of experiences, but there anything that you think we missed or that you would have expected to have seen in there that wasn't in there? And if not, reflecting on some of the messages and who needs to hear these kind of messages. So we've published our research, and we can send the link out to that. It's actually live on gov.uk now, so you can go and read it, the full kind of research document. But is there anybody that you think really needs to hear this, or that we should be reaching out to?
Can you put that link in the chat then, please, Tom?
I can, yeah. Give me a second and I'll find it. I'll put it in there for you.
What we'll do as well, Ted, when we, I'll come to you, Kate. When we circulate the next edition of the newsletter or in an email, we'll also resend the link again. Okay. Kate, you got your hand up? Kate G.
Yeah, yeah. Just a little sort of not the other side of the coin, but we worked with the council to promote the vaccination bans, and I wouldn't say we'd shot ourselves in the foot, but We in June, the first vaccination bans for targeting the Chinese community were in June, and the response was absolutely massive. But the more recent bans, which were sort of mid-August, the response was much smaller. And what it was really was that people, once in between, the government had reduced the wait time from 12 weeks to 8, and people just didn't want to wait until, you know, the 12 weeks, once they knew that they could get the thing earlier. So they went to any pop-up, which was great. And we felt that we'd done a good job in building people's confidence to go to a clinic. But the issue was the people who couldn't understand why they had to even wait 8 weeks. So sometimes it's not a case of trying to persuade people to get the vaccine. It was actually trying to persuade them not to, because they were just, you know, keener. I think the keenest community of all to get vaccinated. So say not really a question, but just a little observation.
Thank you for that, Kate. Any other comments on some of the questions? So, you know, what were the most important messages in that presentation? I mean, as Tom was saying, who else needs to see this link or hear these messages? If there's anybody else got any other comments?
I guess the last question as well is we haven't really touched on, which is what next? How do we build on what's happened in COVID and all of the community champions programs like the one in Birmingham that are really great and have been built up to deal with COVID, but at some point we'll be looking beyond COVID, and what happens to these programs then. So any thoughts around that would be interesting to hear.
I could say something about that again. It's Ruth here. I think that my experience from the past was that the public health community is much better at understanding what voluntary community champions are about than the NHS and including in that general practice. And I think it would be, and that has been a case for perhaps as long as I can remember, certainly with meningitis. Back in the 1970s, there was quite a standoff between public health and charities set up around meningitis as a result of meningitis outbreaks, which subsequently metamorphosed into a really, really strong alliance with public health, both using the charities' information and the charities using local public health, and it really strengthened the response to meningitis. And I don't think, again, that hospital, NHS and general practice were so involved in that. It was between public health and a voluntary organisation. And I think if there is any way to make sure that the NHS and general practice understand better, rather than just public health, what role community champions can play, that would be an enormous strength coming out of this. It came home to me, I went to a national TB meeting when I was working for the charity, which I'd been to numerous times before as an NHS person who worked with tuberculosis. And it was very striking how different my views were received when I wasn't working for the NHS, but I was working for a charity. It was almost as though people didn't really understand what that could be about. So I would say anything that allows, you know, that brings this not just into public health, but into, I know that the NHS has been hugely overburdened with this, and they probably barely had time to think about, is there anybody out there championing it? But anything that makes them aware that there is this resource there and that the resource is skilled and getting on with the job and helping them would be great. Okay, thanks.
Thank you for that, Ruth. Ted, you had, I think you unmuted. You want to comment? You're on mute, Ted.
There we go. Yeah, just to sort of reinforce Ruth's comments, and in some ways the same sort of thing happened to me when I left local authority and started doing started working within the voluntary sector. It seemed that your skills, you leave them in your desk the day you walk out the door and stuff like that. I think in any of your research, was there any exploration of this? This not a negative attitude, but it's and it's not a deficiency attitude either. But there is this hierarchy of knowledge and understanding, and I think sometimes community champions, patients by experience, or whatever we want to call them and stuff like that, are given this almost like the menial tasks. You know, it's like, you know, parents being brought into schools as resources and then washing out the paint pots and stuff like that. Because I think that's one thing we do really have to overcome and have to have a dialogue about post-COVID is, you know, there are very highly qualified people within the voluntary sector. There are very highly qualified people who are volunteering within the voluntary sector. And sometimes those skills and qualifications aren't acknowledged or recognized because they are there and because they've left their work or they're doing it in their spare time or wherever. And I think, first of all, is there anything in your research that identifies that? And I suppose secondly, that's the where next, because that's a dialogue we have to have. Otherwise, in 5 years' time, we'll be back here looking at community champions again and still saying, well, you know, they don't respect the skill level within the voluntary sector.
Shall I answer that? I mean, I think there's several things there. Definitely the research, there are several programs that deliberately sought to really get, I suppose, sort of to recognise the skills and experience that people brought into that. And there were people of a whole range of different skill levels, and the training courses designed to really sort of consolidate, build and share those skills. So I think that's sort of possible. In terms of, was there this sort of negativity and lack of recognition, that didn't come out as much in this research, but in other research that I've done around sort of community-centered approaches, I think that is a recognised issue, that the potential for linking the partnerships with the voluntary and community sector and with communities through community engagement and so on is not as taken up in the health service and not as recognised. It's still quite dominated by the sort of more professional, that's the wrong word because it is also professional, but you know, the more sort of clinical approaches really. And I think that sort of issue has been recognised in other research.
I think if there are no other comments or questions, what I'll do is I've dropped the link to the full document in the chat. So do go away and read at your leisure if you wish. What I'll also do is drop my email in the chat. And if anybody has any thoughts after this meeting or indeed reads through the full kind of document and has something that they want to say, do feel free to drop me a line and share your thoughts and your feedback. We'd really appreciate that. Unless there's anything else that you want to touch on, Jane.
No. Thank you both, Jane and Tom, for your time. As if there are any questions that come up afterwards and they come forward to us, I can always forward them on to yourselves, and I'll share your email address and that link. I'll share it again in the next publication, the next edition of the Champions Update, Champions newsletter that we do, the weekly newsletter that we do, so people can get in touch with yourselves. Someone's asking, is it possible to share the PowerPoint? Yeah.
Yeah.
Okay. We'll share the PowerPoint.
No
Kate.
problem.
Yeah, we'll share the PowerPoint. Okay. Thank you for your time, guys. Both Tom, Jane. Thank you. I mean, you're more than happy to stay on. We've just got a couple of more agenda items, and then we'll wrap up for today. Next on the agenda, colleagues, is any other business. Is there any other questions? Anything else that people have? Just looking for any hands up. No. Okay. If there isn't anything, the date of the next meeting is Wednesday, the 15th of September. As I said earlier, we will have a GP colleague that will join to take some of your GP access questions. Other than that, thank you very much, colleagues. Thank you as ever for your time. Please keep up the good work and championing the public health work that we in Birmingham are doing around not just the COVID response, but wider health issues as well. And we'll see you all in a fortnight's time. Stay safe, take care. Thank you. Bye-bye.